All right, so today I'm presenting a case involving a 74-year-old male with a past medical history of diabetes, hypertension. He's had a stroke in the past as well, a remote alcohol use history. He was brought in by EMS with altered mental status, as well as 1 day of coffee ground emesis and melanoma. According to his daughter, he has never had an endoscopy. He's not currently on anticoagulation or NSAIDs. His initial labs were notable for a hemoglobin of 13 to 14 baseline. His last known value was in 2012 to 9.3 on arrival. His lactate was 9.8. He had a very elevated BUN to creatinine. Several hours after he arrived to the ER, he had 2 witnessed episodes of large volume melanoma with associated hypotension. He received 2 units of blood for his hemoglobin of 9.3, which subsequently rose to 10.9, only to drop to 7.6 a few hours after. And as a result, we decided to perform an emergent EGD at the bedside in the ICU. So on his endoscopy, as you can see in the stomach body, there was a 4-centimeter subepithelial lesion along the lesser curvature with evidence of both mucosal and submucosal destruction by tumor growth. There was an adherent clot that was easily washed off, but no active bleeding was seen. And the stomach was full of a lot of old and clotted blood that we irrigated and suctioned. Given that this large subepithelial lesion was clearly the source of his bleeding, surgery was contacted and he was actually taken for a wedge resection later that day. Here are some representative images of his lesion, and you can see on the right, there's evidence of ulceration. And this is the path from his wedge resection. His tumor was found to be consistent with the gist of the spindle cell type, measuring up to 4 centimeters in its greatest dimension with a low mitotic rate. And the immunohistochemical stains were positive for CD117 and DOG1, with the surgical resection margins being negative for tumor. Today I'm going to touch briefly on GIST. They are the most common mesenchymal tumor, accounting for 1 to 2% of tumors in the GI tract. They do have variable aggressiveness and can be benign or indolent to aggressive and metastatic. And they're usually diagnosed in the 5th to 7th decade of life. In terms of their distribution in the GI tract, they're most commonly found in the stomach, followed by the small intestine, then colon, and less commonly in the esophagus. Most gastric GISTs protrude into the lumen and are actually identified incidentally on EGDs that are performed for other indications. On endoscopy, they can appear as a smooth bulge with a normal overlying mucosa that is often firm in consistency. With surface ulceration, patients can present symptomatically with acute or chronic bleeding, which was the case in our patient. And when you encounter these kinds of lesions on upper endoscopy, it's important to keep a broad differential of subepithelial lesions. And these include lipoma, neuroendocrine tumor, leiomyoma, neurostromal tumors, pancreatic rest, and extrinsic compression from alternative lesions. EUS can be helpful as it helps to accurately depict the size of the tumor, its characteristics, and the wall layer of origin. The majority of these tumors are less than 3 to 5 centimeters in size. They're usually hypoechoic, homogeneous, and solid, though they can also appear heterogeneous with cystic spaces. And most of these lesions arise from the muscularis propria. Histologically, most of these tumors are composed of spindle cells, but they can also be composed of epithelioid cells or a mix of the two. And on immunohistochemical staining, 95% of these tumors will show positivity for CD117. DOG1 is a recently discovered marker for GIST, and it can be useful if the CD117 stain is negative. In our patient sample, his tumor was positive for both. With these GISTs, it's important to stratify them by their malignant potential. And this assessment is usually based off of a combination of tumor size, their location, and mitotic rate. Presently, there is no true consensus on which EUS features best correlate with malignancy. given conflicting results from prior retrospective studies, though some suggest that larger tumor sizes of over 3 centimeters and irregular tumor margins are more consistently associated with a more aggressive phenotype, whereas features like echogenic foci, cystic spaces, heterogeneity, and ulceration are found to be less consistently associated with malignancy. Management is determined based off of size, the tumor size, location, and symptoms, and surgical referral seems to be the mainstay, which should be considered in patients when they are symptomatic and come in with symptoms of obstruction, pain, or bleeding. It should be considered when lesions have surrounding lymphadenopathy and lesions over 2 centimeters in size anywhere in the GI tract, just given that the larger tumor size is thought to be associated with a more aggressive phenotype. And finally, any tumors originating from the small bowel because they appear to have a higher malignant potential. For gastric GISTs that are less than 2 centimeters in size and do not carry high-risk EUS features, there are some data to support the surveillance by EUS at 6 to 12-month intervals rather than resection, though the optimal interval has not been determined. The National Comprehensive Cancer Network guidelines actually recommend that with GISTs over 2 centimeters or smaller lesions that have high-risk features on EUS, that these lesions should undergo resection. So this is an algorithm regarding the management of subepithelial lesions that was published by the ASGE in 2017, focusing on GISTs, which primarily involve the fourth layer or the muscularis propria. There are recommendations to consider endoscopic management, especially if these tumors range 2 to 4 centimeters in size. Although laparoscopic resection remains the standard of care, some of the endoscopic techniques that have been studied include ESD, submucosal tunneling, endoscopic resection, and endoscopic full thickness resection. And here are a few studies that look at each of these endoscopic techniques. So for ESD, he and company utilized it in 145 gastric subepithelial lesions arising from the muscularis propria. These tumors had an average size of 1.5 centimeters, and complete resection was obtained in 92% of these lesions. There was a perforation rate of up to 14%, but all were managed endoscopically, and no local recurrence or distant mets were seen during an average follow-up of 19 months. The limitations with ESD is that it is technically challenging, time-consuming, and it may not be as useful for larger tumors over 5 centimeters because of a reported perforation rate of up to 20% with larger lesions. And additional risks include positive resection margins, bleeding, and tumor spillage because of a disrupted capsule. Now, submucosal tunneling endoscopic resection is a technique that involves creating a mucosal incision at least 5 centimeters proximal to the lesion. Through this incision, the scope is advanced into the submucosal space, and submucosal dissection is then performed until the lesion is seen in the tunnel. Once the tumor is completely resected, it is retrieved through this tunnel, and the mucosal incision site is closed. So Yi and company utilized this technique in 85 upper GI subepithelial lesions arising from the muscularis propria. All of these cases were completely resected with an overall rate of adverse events being about 10%, with the pneumothorax being the most common, and all adverse events were managed conservatively. The rate of complications, however, was significantly higher for lesions originating in the deeper muscularis propria. This was about 70% compared to the more superficial muscularis propria, which is about 1.3%, and this was statistically significant, with the highest complications occurring for GISTs compared to other tumors in the study. Finally, endoscopic full thickness resection. The potential advantages include that its applicability with larger tumors up to 4 centimeters, the ability to perform complete resection of lesions arising from the muscularis propria, and its performance in difficult to access locations such as the fundus and the proximal body. Zhao and company utilized this technique on 26 gastric subepithelial lesions arising from the muscularis propria, with an average tumor size of about 2.8 centimeters. Complete resection was obtained in 100% of cases, and there were no major adverse events reported. All in all, the decision to pursue endoscopic versus surgical resection is really case center and expertise dependent. But I'm curious to hear from our advanced team what their experience has been in approaching these cases.
So a couple things. First of all, it was a really good summary of just those first few slides is basically everything you ever really need to know. I do want to drive home the fact that the small bowel GIST have a much higher malignant potential than the gastric ones. The gastric ones, there's a whole grid of mitotic grade and size that shows their malignant potential. A gastric GIST can get up to 10 centimeters and still be pretty indolent, actually. Whereas like a 1 or 2 centimeters duodenal GIST is fairly high risk for malignancy. So just know that gastric GIST can be enormous. We'll see these on CT scans sometimes of a huge upper abdominal mass, but at the end it might be a low or intermediate potential lesion. The other thing about this case that I really like is that the surgeons took the patient to the OR without getting an EUS in tissue. We get asked to biopsy these things all the time, to which we usually say, they bled. I don't care what it is, get rid of it. And it's a wedge resection. It's not a gastric cancer. It's clearly subepithelial. So I commend the surgeons for sort of just acting on this and not sort of diddling around for waiting for PATH and EUS and so on. So this is, I think, the right way this should be managed. In terms of, and I like this ASGE algorithm a little bit. Myself, I was a skeptic about having these GISTs removed with ESD or EFTR. I initially, a handful of years ago, thought this was just endoscopists showing off. These are low risk lesions. But now, having worked with Nikhil and also seen the data evolve over the years, it's quite safe. They show a perforation right here, but many times that perforation is intentional. It's to get it off the muscle. And it's not a complication like perforation in the colon from a polypectomy, which is a different issue. And so these are very controlled perforations. Even intraprocedural bleeding is very controlled and readily managed. So some of these complications may be a little overstated in this grid format, but I've actually changed my approach to this. This is a really safe procedure in experienced hands. Nikhil has been stellar at this, and many of the other experienced, I add that caveat, the experienced people in New York City have been very good with this as well. The surveillance of these things is really annoying. If you think about it, a 50-year-old coming in every 2 years for an EGD or an EUS is just not resource practical. And you can't underestimate that this makes some people very anxious. When you tell them you have a thing that's growing, that's a tumor, nobody likes that. And there's a real mental wear for many patients that I don't think we appreciate. So now that there's a safe, it's like an hour and a half procedure, which could be just a tough colonoscopy when you think about timing. Anything that's over 1.5 centimeters, I usually send over for endoscopic resection, because then it's gone. It's cured. There's nothing to do. You don't need to worry about it anymore. So I think that, and I'd encourage most people, anytime they get referred to me, I've been referring all of these on because we should get rid of the surveillance stuff for life on these young patients. Any other comments out there? If you could scroll back a couple of slides to the picture of the GIST, I did want to point out one thing before we move on to Ji-Yoon's case. Right there. So this is a pretty good appearance of it. You see how there's sort of sharp borders at the junction of the lesion on the stomach wall. I tend to find lipomas have sort of softer edges. They're not as sharply demarcated. So one can risk stratify as an endoscopist. Is it firm? That might make you think of a muscle tumor. That's how I describe these to patients. And also, are those borders very sharply defined like they are sort of here? And I tend to see this more in GISTs. It's important to tell patients when you found something in the stomach that it's not a cancer. About half the patients who come for an EUS are freaked out they have a stomach cancer. And so I make it very clear this is a semi-benign muscle tumor is how I sell it. Any other comments?
Hi, Steve Nikhil here. So Christina's smiling because I remember we did this case at like 4 in the morning, and the patient had a pretty massive hemoglobin drop. And as you alluded to, as soon as we saw this, we knew it was a GIST. And so I think it's very surgeon specific to really get the correct treatment of choice, which in this case was an easy enough wedge. And so I called the surgeon specifically to make sure that we could bypass, getting a tissue diagnosis, because this was not concerning at all for a gastric adenocarcinoma. And so literally within a matter of a few hours, that patient was in the OR. And I think that also, owes to, communication directly with the surgeon so that you don't delay patient care. And, one of the higher risk factors and indications for surgical resection, are these, bleeding ulcerated GISTs. But I would echo your comments that, with respect to those guidelines, particularly for the smaller GISTs, the trend now is moving towards endoscopic resection because it is very safe. And actually, the reason why we don't go after lesions that are more than 5 centimeters, it's not that we can't physically cut them out. It's very hard to physically remove them, because remember, with GIST, you need to keep the capsule intact and you don't want to fracture it. So if you have a 6 or 7 centimeter gastric GIST, we're not going to be able to pull it out through the GE junction or through the upper, esophageal sphincter or out through the mouth. So oftentimes those end up going on to surgery. And even for the larger GISTs, like the greater than 10 centimeters that you talked about, the surgeons will oftentimes give the patient Gleevec or imatinib to try to shrink it and improve their surgical chances. The only caveat is that some locations are harder in the stomach to do these types of resections. So the fundus in particular, because you've got to work in that U-turn retroflex position, that can sometimes be challenging. So if they're really small in that case, like, 1 centimeter or less, then those are the ones that I'll opt to survey. But if it's, bigger than, to be honest, like 10 millimeters, 15 millimeters, even if it's under the NCCN guidelines, as Satish mentioned, patients will have a thorough discussion with them in the office, but more than likely they're going to opt to have that just resected so that they don't have to undergo, long-term surveillance and that anxiety that, that may come with it. So I thought that was, a great presentation that you did. I remember this case very vividly, and I think your slides were great. And I would just, highlight that for our patients, we can really offer a great endoscopic resection. They have outstanding results. And I think the comment Satish made was very pointed about those perforation rates really aren't perforations. You have to cut it off the muscle. So the reason that the tunneling technique is probably the preferred approach now is because you don't have one, sort of full segment of stomach wall that's completely breached from the mucosa through to the serosa. It's a tunneled approach. So, proximally you have your mucosal incision, then you're kind of tunneling through with submucosa, and then, closer to where the lesion is where you're having your muscularis propria dissection, or sometimes even a full thickness dissection, just distally of the muscle. So it's sort of a controlled, like almost like that Z-line technique that you use during, like paracentesis. So it was a great presentation, great case.
All right, Ji-Yoon, let's have you take it over here. That's good. Go ahead.
Okay. All right. Good morning, everyone. I wanted to present a case I came across on consult, which is a little more surgical. This is a 60-year-old lady with end-stage renal disease on hemodialysis, history of an esophageal adenocarcinoma, had an Ivor-Lewis esophagectomy. The path showed she had T2N0M0 disease with Barrett's, on a background of Barrett's esophagus. She is presenting with recurrent vomiting and coffee ground emesis, which has been ongoing for about a month after her esophagectomy. Her operation was successful. She was discharged on day 9 without any particular complications. She is now tolerating minimal oral intake without vomiting, but she is passing stool and gas and not complaining of any abdominal distension or abdominal pain. On the right here is her initial EGD showing a nodular lesion, which turned out to be her esophageal adenocarcinoma. So just to go over the anatomy of the Ivor-Lewis esophagectomy, initially a laparotomy is performed. That's to mobilize the stomach from the surrounding structures. A pyloroplasty is performed to prevent delayed gastric emptying, and then the surgeon also performs a lymph node dissection. The patient is then turned onto their left lateral, and a right thoracotomy is performed. The stomach is mobilized into the thorax. The esophagus is mobilized with a resection of the tumor. And then the anastomosis is performed between the stomach and the esophagus. So back to our patient, she underwent a CT scan in the emergency room, which this shows. So this is a represented image. As you can see, that is the thoracic conduit with the air fluid level. It looks pretty dilated. And then we were asked to perform an EGD on this patient, firstly to evaluate the cause of the coffee ground emesis, possible bleeding, and to look at any signs of for any signs of obstruction in the conduit. So these are the first images that we found on entry. This is her esophagus. She has a lot of esophagitis. She had a lot of fluid built up in there. And then you can see the thickened area on the bottom at around 5 o'clock. This is her esophagogastric anastomosis with surgical staples. Next is an image of her thoracic conduit. So you can see that it's extremely ulcerated. There's a lot of erythema, bleeding without contact. And then here is a fold beyond which is her diaphragmatic pinch. So her conduit is very dilated, and then we can see a fold beyond which we proceeded. This is her distal, this is her conduit beyond the diaphragm. So everything looks pretty good, normal mucosa. We passed through the fold pretty easily without any resistance. This image is of the pyloroplasty. It's wide open, no resistance to passing the scope. And then beyond that, the duodenum was entirely normal. So what I wanted to talk about today was delayed gastric emptying from a GI perspective. I'm sure there are surgical colleagues that are better qualified to talk about this, the surgical perspective of this. So occurs in about 15 to 40 patients after esophagectomy, and the mechanism is thought to be because of the complete vagotomy from mobilizing the stomach, resulting in decreased contractility and increased pyloric tone. There's a lot of literature about whether pyloroplasty procedures to reduce pyloric tone, so whether that be a finger disruption of the pylorus during the surgery or pyloroplasty during the surgery as well. And it seems to be that performing these procedures helps reduce the incidence of delayed gastric emptying after surgery. So, and then there's also decreased blood supply, which reduces gastric motility. The symptoms are, as you might expect, early satiety, nausea, vomiting. There's a lot of regurgitation, and then the inability to meet caloric need by oral intake. The post-op course of an esophagectomy is fairly morbid. It's very common to lose about 15% of body weight from diagnosis to 6 months post-op. Unfortunately, it levels off thereafter. And then there are other disorders that affect post-op quality of life in the gastric conduit patient, reflux dysphagia and dumping syndrome. So usually these patients are obviously still seeing their thoracic surgeons, but if they happen to enter into our world through the ED or via our clinic, I was thinking, you know, a simple and easy imaging technique without going through the full CT might be a chest X-ray. It's very suggestive. So this was her chest X-ray. You can see that the thoracic conduit is taking up most of her right thorax, and then you can see an air fluid level, and the air fluid level is very suggestive of delayed gastric emptying in these patients. So what do we do about these patients? There are no guidelines, as you might expect. However, there have been studies that demonstrate that motility agents are effective in these patients. Reglan has been tried. There are obviously a lot of problems with patients being on these agents for a long time, especially with tardive dyskinesia. So the first line agent is erythromycin, and it has been shown to be effective starting immediately after surgery or several months after surgery if this presents later. Recommend high dose PPI to treat reflux because there is a lot of stasis. And then NJ tube if the patient is unable to meet their caloric needs. And it seems like usually they're able to remove that once the motility returns somewhat. Sometimes the pyloroplasty is not successful, or it was not performed during the initial surgery, and then we can help by relieving the obstruction. So endoscopic options are an endoscopic pyloric balloon dilation and intrapyloric injection of botulinum toxin. And I think the pyloric balloon dilation is slightly more preferred, although I don't know the exact data behind that. There is a gradual recovery of the contractile function of the conduit over time. So the patient is eventually able to tolerate a little more oral intake and maintain their weight, hopefully without the feeds. I was wondering if anybody else had come across this and whether they had experience in managing these kind of patients.
So I will say I've seen a lot of patients with this. This is a great presentation. This comes up fairly often. And I tell like fellows, trainees, residents all the time, like of all the GI surgeries that like we see, the one that I would least prefer for myself is an esophagectomy, because the stomach doesn't belong in the chest. There is no room for expansion of the stomach there. You've got thoracic pressures that alter the motility and function of the stomach in addition to the vagotomy. It's just not a great place for your stomach to sort of live. I've done both the Botox injection and the pylorus, as well as the pyloric balloon dilation. I don't really have a sense of one's better than the other, but I will say that a lot of times you have to do this early on post-operatively. And then I have seen many of these patients will get somewhat better over time. Patients never really get normal, right? Like after a distal gastrectomy, patients kind of do okay. But after a esophagectomy, their lives are very different. You don't have an LES and all the other issues, and then as well as all the other issues we just talked about. It is important to try not to overstretch that conduit. It's a straight shot from the anastomosis down to the pylorus, essentially, when this is done optimally. As that in your X-ray, which is really good, that conduit has sort of a J shape to it. And that ends up behaving almost like that little, J-shaped pipe under your sink. And there's a lot of stasis in that turn. And if that becomes a permanent configuration, then you have an anatomic problem. You've got like a recessed area for food to sit. So I try not to push these patients too hard. NJ tubes, PEG tubes, all those gastroparesis diets we put people on, Reglan, domperidone. You don't want them to end up with a big baggy conduit that will fail them in the years to come. Any other comments?
Yeah, it's just a really bad problem. And there's no great reason why. I mean, stretching the pylorus or injecting Botox, like it's hard to understand even why those are even going to work. So, I mean, we do them, but you're right. It's not a good operation to begin with from our point of view. Do the surgeons have any comments as Ji-Yoon was asking? May not be any on.
I don't see any.
I have a question. While I was looking into this, there was a lot of literature that was debating whether the entire stomach should be mobilized or whether a gastric tube should be made. This is obviously kind of out of our domain, but have you noticed any differences in maybe patient outcomes after those two?
Normally, the stomach is tubularized. You know, they don't just lift it up. They sort of remold the stomach. That's why they call it kind of a gastric conduit. Usually, it isn't just the native stomach just pulled up. They kind of slice it down around the cardia, and then they kind of change it so it's more tube configuration. But I'm sure there's some variances there that are not obvious to me. The other type of surgery, I don't think we do that much here, but because our thoracic surgeons do a lot of the esophagectomies here, but in some places you have GI surgeons who do it, and they don't really like hanging out the chest. So they do their anastomosis up in the neck. It's called a 3-hole esophagectomy. And they pull the whole thing up. The anastomosis is around 18, 17 centimeters. The advantage of it up here is that if there's a leak, it's in the neck and not in the chest. And then for a GI surgeon, they don't want to be in the chest anyway. But I have found I don't like that surgery very much. That anastomosis is so high. So when there's problems up there, it's very hard for us to do anything because it's just under the UES. Any other comments?
I see Dr. Ruben's hand is raised.
I was just going to ask what the surgical alternatives were, since this is such an objectionable operation on many fronts, but it's a bad disease and a bad location. And the question is, what's better to get rid of the cancer?
I don't know if any of the surgeons are on, but I will say from my own experience in asking this question to surgeons and oncologists, there isn't anything else. You know, I mean, obviously you come back to sort of Barrett's and screening and early cancer and endoscopic therapy, but here you got a T2 tumor. You can give chemoradiation, but the recurrence rate is much higher if you don't go follow up with an esophagectomy. So it's just kind of a bad situation, unfortunately. A colonic interposition sometimes sounds nice, but it's far worse. And those patients end up doing uniformly not great 10, 15 years later.
So this is an argument for keeping on top of Barrett's screening and watching your Barrett's patients.
It's interesting because I think something like 70 or 80% of esophageal adenocarcinomas are in patients who did not have a known history of Barrett's. There is Barrett's microscopically, it's just we didn't know. And so all of this obsession we have over finding Barrett's, surveilling Barrett's, and following Barrett's closely is unfortunately the wrong piece of the pie. But you're right, for the Barrett's patients we do have, we need to follow them. Nick.
Yes, I will share.
Fire away. Thanks, Jude.
Thanks.
All right. Today I'm going to present yet another unusual gallbladder triad to go with our other unusual gallbladder triads of Gallstone ileus and Bouveret syndrome. So this is an 85-year-old female. She has a history of coronary artery disease, and she had a STEMI 4 months ago and had a stent placed, so she's on ticagrelor and aspirin. And she presented with abdominal pain. She was hemodynamically stable, and she was initially had mildly elevated liver enzymes that within 24 hours rapidly became much worse. Her TBLA jumped from 2 to 4, her AST was 1,000, ALT 800, her alk phos jumped. So she had imaging, and her gallbladder was found to be distended with sludge. On the left, you can see an ultrasound. The gallbladder wall is thickened. There's a little sludge in the bottom and these little wispy pieces of sludge floating around. On the right, you can see sludge towards the bottom of the gallbladder layering. And she also had biliary dilation with the common bile duct measuring 1 centimeter. So because of the jaundice and the biliary dilation and the sludge, she was presumed to have choledochal lithiasis and went for ERCP. So when we went in, there was actually blood spontaneously flowing from the major papilla here. On the leftmost picture, that's the ampulla on the rim of a diverticulum. That's why it looks dark. And that blood was before we did any procedural intervention. So this was just spontaneous. After cannulation and we opened up the orifice a little bit, there was even more blood flowing. And then we placed a biliary stent and blood was just flowing through the stent. We obviously shot a cholangiogram as we do, and there wasn't really a clear stone or filling defect. And so, sort of in retrospect, because we weren't looking at the labs at this, the hemoglobin that closely, we noted that she actually had a 2-point hemoglobin drop since her admission, probably from this oozing. She was hemodynamically stable, but we sent her for a CT angiogram to see if there was any active extravasation. And just to compare, on the left was the CT the day before the procedure, and we saw again the gallbladder with some sludge. On the right, you can notice a density change between this pre and post image. On the right, this was after the procedure, and now there's high density material filling the gallbladder, which was presumed to be blood. So we actually diagnosed her with hemorrhagic cholecystitis. The reason probably she was jaundiced is that that blood from the gallbladder can flow into the duct and clot and then cause biliary obstruction. So her ticagrelor was held. At this time, because of the bleeding and the risk for further bleeding with surgery and the fact that she was improving clinically with conservative management, surgery was deferred at that time. And then she was discharged a few days later. She has been subsequently seen in clinic doing totally fine with the biliary stent. And then yesterday, we actually took out the biliary stent. There was no more bleeding, swept a little sludge from the duct, and she's doing totally fine in the outpatient setting. So this is the rare triad of hemobilia, which we don't really see, and you may not even see the full triad. So in her case, we didn't have each piece, but they can present with biliary colic, obstructive jaundice. Again, that's from clotting in the duct leading to biliary obstruction. And then they could present with hematemesis or melena. If it's significant enough bleeding, they can have overt GI bleeding as well. The most common cause of hemobilia is usually going to be some sort of biliary intervention, either a liver biopsy, a percutaneous IR intervention, a surgery, ERCP, something that involves manipulating the bile ducts that's leading to bleeding. The other thing to think about in someone who hasn't had a procedure is always going to be cancer. So do they have a cholangiocarcinoma, a gallbladder cancer, or a liver tumor that's bleeding, invading into the ducts and then bleeding out into the ducts? It can also be caused by more common, just generic things like trauma, or gallstones due to inflammation can cause bleeding, or cholecystitis from the inflammation, again, can cause bleeding. In this case, hemorrhagic cholecystitis is sort of like a subset of things that can cause hemobilia, but it's bleeding from the gallbladder itself. And then the blood from the gallbladder can go into the bile ducts. And it can cause cholangitis. It can mimic cholecystitis. Similar risk factors to just overall hemobilia, so usually trauma or malignancy. In this case, the patient was just on anticoagulation. And so the theory was, essentially, she had some sludge in her gallbladder, it was probably causing some inflammation. She was on a blood thinner, and that caused bleeding. It was enough with the combination of inflammation in the blood thinner to cause bleeding in the gallbladder, and then that led to all her problems. So the ultimate solution would be surgery to take out the gallbladder if the patient's a good surgical candidate. Again, the surgery was deferred in this case, just the patient was older with a lot of comorbidities. But she actually did well, luckily, with conservative management. So that is it.
Great, thank you, Nick. It is a very surprising thing when you see it, because I mean, I remember walking in the room when you guys did this case and there was just blood pouring out of the ampulla.
Yeah.
And I like how you first say, it wasn't our fault. Bleeding before we got there, I swear. But so just a good point, because a lot of times they bleed after we get there.
We do cause bleeding, but not in this case.
Most of the time we see hemobilia, it's usually in the context of some kind of horrible cancer, or again, so like usually known malignancy, or new diagnosis, cholangio, gallbladder CAs. All the times I've seen it, usually the patients are in extraordinary pain, largely because there's such an incredible expansion of the bile duct with blood and clot. And then eventually when that duct expands so much, there's stasis, and that's what makes them stop bleeding. But all the times I've seen this, they've been in just really bad pain. And so sometimes you have to repeat that procedure fairly quickly because your stent gets clotted. And so after you reverse things, so, sometimes we just go back in and repeat and clear it out again. So thankfully she did really well. We were pretty concerned about her when she was here. But yeah, looking for that obstructive jaundice, drop in hemoglobin, those are all sort of good tip-offs that may be hemobilia. Peter.
What are you going to tell the cardiologists when they want to know if they can restart the anticoagulation?
This was a big discussion. So after she stabilized, we discussed with the cardiologist, and given her recent stent, we actually restarted the anticoagulation. And we were confident, at least that she did well with the biliary stent, that she wasn't going to have biliary obstruction. But, there was the risk of recurrent bleeding, but she luckily did well.
So cardiologists really love their anticoagulation, as I think we all have learned. Other sort of comments before we move on towards grand rounds?
Used to see this after liver biopsies once in a while.
Mm-hmm.
I haven't seen it in a long time. I'm not sure if that's because of better ultrasound guided liver biopsy technique or just happenstance. But.
Although I think that might have been, I don't know if people are doing that many blind liver biopsies anymore.
Right. So,
even I did blind liver biopsies, for goodness sake. And it was great because it only took like 2 seconds, but then they sat and pack you for 4 hours. So because somehow it was thought that putting them right side down would tampen out all that bleeding that occurred in the liver parenchyma, which sure. All right.
Question before we stop. Is there any argument for not putting in the stent and not draining the CBD if she is actively bleeding for a tamponade effect in the absence of cholangitis?
Yeah.
I think again the issue usually is pain, because again that rapid obstruction and then that clot sort of propagates up into the liver, so you end up with a rapidly progressive biliary obstruction sometimes. So usually the paradigm is clear out the duct and stop the bleeding. And so unfortunately, yeah, if you just let it clot, then you're just going to have just this ongoing biliary obstruction. So there's really not a good way out. In the cases of cancer, we often just send them down to IR and embolize the tumor. Most of the liver tumors are fed arterially. So you can knock out selective branches of the hepatic artery, and that usually fixes the problem. Generally, this is fixable. Get the gallbladder out or embolize the tumor. It's rare that you're sort of left in a really bad scenario.